The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC. And this morning I'm talking to Dr. Rodés-Cabau, and Josep is the director of the Cardiac Catheterization Laboratory at the Quebec Heart and Lung Institute, and he's the primary author on a very nice study that addresses the degree, the prevalence and degree and significance of left ventricular dysfunction that can accompany percutaneous aortic valve implantation, or TAVI as it's come to be called. So, Josep, let me ask you, what degree of biomarker elevation is required before you would think that there's been some evidence of myocardial injury?
In fact, here in this study, we measured the biomarkers of myocardial injury at baseline at several times after the TAVI procedure, and we established as our upper limit the usual upper limit that is used in our laboratory. This is 0.04 micrograms liter for the cardiac troponin T, and 10 micrograms liter for the CKMB. And we measured any degree of myocardial injury. We defined any degree of myocardial injury as any elevation of these biomarkers above these upper normal limits.
Okay, so even the least little bit of elevation was enough. So how prevalent was it that you had evidence of increased biomarkers in the setting of TAVI?
Mm-hmm. In fact, when you look at the cardiac troponin T, was more than 95% of the patients, and this was irrespective of the approach, transfemoral or transapical. And when you look at the CKMB, this was about 77% of the patients, more than 90% in the transapical group, where you are performing a direct puncture of the apex, and about half of the patients in the transfemoral group.
Well, if it's so prevalent, does it have any significance if virtually everybody is having elevation of biomarkers?
In fact, we look at the potential prognostic value of this biomarker increase after the procedure, and we found that a higher increase in these biomarkers was associated with a less improvement in left ventricular ejection fraction at follow-up. And specifically, the cardiac troponin T, a higher increase in this biomarker was also associated with a higher cardiac mortality at midterm follow-up.
So is there some level of biomarker elevation that really predicts a high risk of a low ejection fraction or an increased mortality?
For the ejection fraction, we found that CKMB that was about 3 times the upper normal limit was associated with less improvement in left ventricular ejection fraction, and this cutoff was 10 times the upper normal limit for the cardiac troponin T. When we are talking about cardiac mortality, the cutoff for the cardiac troponin T was more than 15 times the upper limit.
15 times.
Yeah.
So why does myocardial injury occur?
This is a very good question. For the transapical approach, for sure, we are performing a direct puncture of the apex of the heart, introducing large catheters through the apex of the heart, and this for sure can be induce some degree of myocardial injury, as we have seen. For the transfemoral patients, is less evident. There's always some kind of severe hypotension and global ischemia during the procedure. You do the valvuloplasty. We induce a ventricular tachycardia at least 2 times during the procedure. And we are also stretching the myocardial septum with the balloons and with the valve. And we cannot exclude neither the occurrence of coronary microembolism. We have seen also in the brain a lot of cerebral emboli associated with this procedure, and we can speculate that maybe there are some kind of coronary embolism that can occur.
Well, very sobering, perhaps not surprising, but it's clear from your work, even though the group was limited, that evidence of myocardial injury is very common with the TAVI procedure for aortic valve stenosis, and that it does have some significant consequences. Hopefully, as technology improves and experience increases, that'll be less and less. Thanks very much for being with us. For Inside JACC, I'm Tony DeMaria.